Welcome to the Public Health Workforce Pipeline for the first session of our Passport to Public Health. Today's destination is epidemiology. And my name is Dana Farah, and I'm the Program Manager for Continuing Education at the Texas Epidemic Public Health Institute, or TEPHI. And today we are pleased to welcome Dr. Catherine Troisi, who is Professor of Divisions of Management, Policy, and Community Health and Epidemiology at UTHealth Houston School of Public Health. So we're going to start off talking about the public health workforce pipeline. Our goal is to create a sustainable and inclusive public health career pipeline that fosters interest, skills development, and professional growth in public health through a strategic collaboration between educational institutions, clinical and non-clinical professions, and public health leaders. This particular community is the Communications Committee, and our goal is to develop strategies to share public health information. The goal is to inform, support initiatives, and involve stakeholders. So on the left, you can see what is public health. I can let you guys read this, but what I will talk about is the series, the Passport into Public Health webinar series. It's designed as an educational journey introducing students and young professionals to the diverse world of public health. We're calling it a passport because we're guiding participants through different destinations, each representing key topics, careers, and real-world applications within the field of public health. So some webinar housekeeping. If you want the live transcript, you click on the CC at the bottom and then click on live transcript. And if you have a question that you would like to ask us or Dr. Troisi, please click on the Q&A at the bottom. And then we pretty please ask that at the end of the session, we will have a QR code for our survey, because we would like to know what you think of this presentation and what you would like to see in future presentations. So to start off, we're going to do a little icebreaker. What is one skill, characteristic you believe is essential for success in public health? Please use the QR code to join in. And I believe, did we post the link in the chat?
Yes, the link's in the chat.
Perfect, thank you. And then are we going to share the results in just a minute so everybody can see? Mm-hmm. Communication, communication, communication. All right. Well, thank you guys for filling that out. I see that communication is very essential, and I think Dr. Troisi will probably discuss that a little bit with her presentation. Okay, so to introduce Dr. Troisi, she's an infectious disease epidemiologist and professor at UTHealth Houston School of Public Health. She plays a major leadership role in TEPHI, and she's previously practiced public health as assistant director at the Houston Health Department, where she served as incident commander for Katrina and H1N1 pandemic responses. She holds a PhD in Epi from University of Michigan and completed national public health leadership training. Dr. Troisi was elected to AFA Executive Board, is currently serving as chair of the Evidentiary Review Committee, as well as chair-elect of the International Network of Epidemiology and Policy, and many local and state public health advisory boards. She is a co-editor of the Control of Communicable Disease Manual and recipient of the 2018 ASPPH Academic Public Health Practice Excellence Award. And I'm attesting to this. Dr. Troisi has given 585 media interviews since 2020 because she's so well respected in her field. So I hand it over to you, Dr. Troisi.
All right, thank you. Good morning,
Yeah.
everyone. So today we're talking about epidemiology. So, you know, when I entered graduate school many years ago, to be honest, and I'll tell you about my career path, but I had never heard of epidemiology, and most people hadn't. A lot of times you would get asked, is that about skin diseases? But now, after the pandemic, I think a lot more people know what epidemiology is, or at least have some idea. And the primary purpose is to understand, to describe, and to control health-related events within a population, particularly diseases, whether communicable like I study or chronic diseases. So you have to look at these patterns, causes, and the effect of other health issues to guide interventions, because the ultimate goal is we want to stop those diseases from affecting populations. And in fact, Dana gave a great definition of public health, but you can put it more succinctly that public health, the two goals of public health are to prevent disease and promote health. Epidemiology is known as the queen of public health because it is the basis for almost everything. Now, I admit I'm biased, but a basic understanding of epidemiology is, I think, necessary for whatever you're going to do in public health. And indeed, that's why epidemiology is one of the core courses if you do study public health. So even if you're going to study climate change, you still need to know something about how to do epidemiologic methods. So again, Dana alluded to this, but how does it differ from medicine? Public health is population-based. We're looking at the population as a whole and finding ways to make the population healthier, sometimes by mandates, sometimes by making the healthy choice the easier choice. Medicine is based on the individual, and obviously we need both of those. If I'm sick, I don't care what the rest of the population is doing. I want my doctor to help me get better. So there's a lot of overlap. And in order to create a truly healthy world, we need both of them, and they must work together. So you can think about the diagnostic tools of each of those areas. In medicine, often your temperature is taken when you go in for a visit. We use demographics in public health, that is looking at birth rates and death rates and distributions of populations. In medicine, we've got a stethoscope to listen to your heart. Again, vital statistics is a portion of demographics. You know, what are people dying from? Are babies healthy when they're born? That kind of thing that we can get from data from vital statistics. And then whereas medicine gets your individual data, your history, public health uses epidemiology to diagnose a population. So the next slide, please. So a typical work day's a little hard to describe because in my career, and I think, let me look ahead. I think I go into this, a little bit later. I've done a lot of different things. And so I may not be your typical epidemiologist. And so on a given day, I teach classes on epidemiology, on leadership, on, basically epi and leadership and public health as a whole, basic public health. I attend a lot of meetings. I also have research studies that I work on. And then as you saw in my bio, I do a lot of service to the profession. I'm very active in the American Public Health Association. We have our annual meeting coming up starting, well, I have to be there this Saturday. And I'm on a number of committees with leadership positions. So it's a very busy meeting, but that takes a lot of my time. Also, the International Network of Epidemiology in Practice, INEP for short, is also something I spend time on, helping to write policies for them on public health issues. For example, I just led a working group that wrote a policy on vaccine hesitancy, which you may be aware is a big issue, not just in the United States, but around the world. So how do we address that? Yeah, that's about it. Now, when I was at the health department, my day was much different. As again, in my bio, you saw I was incident commander. That means you're the person in charge for Houston's response to Katrina, for many small events that we had, but also for influenza H1N1 in 2009 that we didn't know how bad that was going to be. Luckily, it wasn't as bad as we thought, but we still had to have a response to it. When I was assistant director at the health department, I spent a lot of time on personnel issues. When I was bureau chief for HIV STD prevention, I spent a lot of time in the community talking to groups that did the actual work of prevention. The health department, we did some, but a lot of contracts were written for nonprofits to do the work because they were in the community. So I do a lot of media right now. That's an old number. With, COVID still in the news, flu. Mostly I do interviews on infectious diseases, but sometimes on other issues. And then also, again, just networking with other people in the field. As I said, I've had a varied career, and there's a couple of reasons for that. So when I was in grade school, I loved to read. I still love to read. I loved to write, and I thought I would be a writer when I grew up. And then when I was in middle school, I wanted to be a senator. Yeah, that wasn't going to happen. But and I hated science. I would get A's in everything and B's in science because it just didn't interest me until I took biology. And I loved biology in high school. And I decided, I'm not actually sure why, that I wanted to study biochemistry. And so when I went to college, back then, the college I went to didn't have a major in biochemistry, so I was a chemistry major. And then I went into a PhD program in biochemistry. And it took me about a month to realize this was not what I wanted to do for the rest of my life. I'm glad people do it. It's important. It just wasn't right for me. But I had the advantage of learning a lot of lab skills. So then I decided what I really wanted to do was study viruses. And at that time, and this is still true today, at the University of Michigan, the virology work is done in the Department of Epidemiology. Now, I've confessed, I wasn't really sure what epidemiology was, but I wanted to study viruses. So I went to Michigan, and I did a lot of lab work working with influenza, but I had to take epidemiology courses as well. And I fell in love with epidemiology. I think, well, I'll save that to the end. Okay, so my husband, we were married. He also got a PhD from Michigan and went on the job market before I did. And so I'm from the Northeast. The year he went on the job market, in his specialized area, there were 4 jobs in the whole country, and one was at Rice University. And he says he can still remember the look on my face when he told me we were moving to Houston. But it turned out to be a good place because of the Texas Medical Center. And he just retired after 46 years at Rice. So I've been in Houston my whole career. I postdoced at Baylor in the Division of Virology and Epidemiology under a very famous virologist, Joseph Melnick. He had a lot to do with polio, a lot of important research on polio that helped lead to the vaccine. I was then put on the faculty, and I was doing lab work this whole time. I ran a clinical lab for hepatitis, and then while I was at Baylor, HIV came on the horizon. And so we also did testing for for HIV. I was involved with clinical trials of hepatitis C and also vaccine studies for hepatitis B. So I was there for, I don't know, a while, a number of years. And I decided that I wanted to get out of the library and I can't talk. I wanted to get out of the laboratory. And so here, the School of Public Health, basically across the street from Baylor. And so I was hired on the faculty here. I didn't do lab work. I still did some vaccine trials and some other HIV and hepatitis research. I was here for 7 years, and then I decided that I wanted to really practice public health. Now, I've told you that my husband was at Rice for 46 years. My dad was dean at a college. I lived in an academic bubble. But I went to the Houston Health Department really not knowing what to expect, and it was a huge change. There is a big cultural difference between academia and practicing public health. Again, both are necessary. I started as bureau chief for HIV, STD, viral hepatitis prevention. I was promoted to assistant director over communicable diseases, along with the area agency on aging and jail health. It was sort of strange. As I said, as an administrator, I spent a lot of my time on personnel issues, which I didn't think was the best use of my scientific training and really not very much fun. And so I was going to go back to academia, and the director wanted me to stay, so he let me create my own job. And we created this director of public health practice where I would deal with workforce development, because at heart, I'm a teacher, as well as research collaborations with the medical center, because here in Houston, the Houston Health Department is only a mile from the medical center. In fact, I think technically it's part of the medical center. But there isn't a whole lot of interaction. And whereas the medical center, besides the clinical work that's done here, research is a main aim. The health department, they got their hands full. They're not doing a whole lot of research, but they're good collaborators. And so my job was to foster that collaboration. And it helped that I had a lot of contacts here in the medical center from my time here. And then I also worked on policy issues. And I did that for a couple years. And then I realized I wanted to go back into academia. So luckily, UT took me back, and I've been here ever since. I think you can tell from my career path that I get bored easily. And one of the things that is so great about public health is I've done all these different things. They're all public health. And biochemistry, I didn't want to study one protein for the rest of my life. Again, I get bored easily. So that public health is just a great way to use your skills in a variety of ways, whether it's teaching, whether it's research, whether it's working with nonprofits, whether it's public health practice, where you're actually out there doing things. I've been back at UT for 15 years, hard to believe. And there are things about public health practice I miss, the immediacy of it. Hopefully, I'm making a difference in my academic career. But when you're doing public health practice, you know right away the difference that you've made. So I do miss that part of it. So whatever you decide to do, each has its advantages and disadvantages. Okay, I'm not sure what's on the next slide. So one of the, I'm going to say most important, particularly if you're doing infectious diseases. And let me step back. I'm an infectious disease epidemiologist. I mostly study viruses. Other people study bacteria or fungal diseases or mosquito-borne diseases, which are often viral. I do blood-borne diseases and respiratory diseases, but there are many other paths in epidemiology. People study chronic diseases, for example, diabetes, heart disease, asthma, things like that. There's a field called clinical epidemiology that really combines medicine, but uses epidemiologic techniques. We can look at the epidemiology of gun violence, for example. Almost anything can be studied using epidemiologic methods. We have a big group here at UT that studies aging, some of which is epidemiology of that. Now, everybody ages, but you can look at diseases or conditions that are more common as we age. But if you are interested in infectious diseases, then it's really important to know the difference between incidence of a disease and prevalence. Incidence is how many new cases of disease are happening. So we express that as a rate. A rate means that it has a time component. So during COVID, we were talking about number of new cases per day almost, or per week. If we're talking about, for example, diabetes, we may look at number of new cases per year. So that's the number of new cases. Prevalence is how many cases exist at a given time. So you can think about this as a bowl with a funnel. And the number of cases in that bowl are everybody who has it, whether they got it, for example, with diabetes 20 years ago, they're still in that bowl. They have not gotten rid of diabetes. And then the new cases are being added through that funnel. So what's happening, what the cases that are going in that funnel are the incident cases, we call them. So that's incidents. And then the prevalent cases are everybody who has it. With an infectious disease, there sometimes isn't a whole lot of difference between those numbers, because if you get sick with food poisoning, so the incidence would be how many people this week had food poisoning. But people aren't usually sick for more than a day or two, unless you're really unlucky. So so people exit that bowl pretty quickly. They go in when they get sick, but they don't stay sick a long time. They leave the bowl. I guess there's a drain at the bottom of it. And so they're no longer counted as cases. So with infectious diseases, sometimes there's not a whole lot of difference. With chronic diseases, then there can be a very, very big difference, as you can imagine, because again, diabetes as an example, you don't get rid of it. Once you are an incident case, maybe you were, and sometimes it's hard to tell when it actually happened, and we might use the date of diagnosis. So if you were diagnosed in 2020, you are still in that bowl in 2025. So I hope that was clear. Ask me questions if it wasn't. So how do epidemiologists identify and control outbreaks in rural or underserved communities with limited health infrastructure? This is obviously a big problem, because epidemiologists need data. During the pandemic, particularly at the beginning, if you remember back 5.5 years, we didn't have testing right away. And many of the interviews I did, I used the phrase that testing was the eyes of the epidemiologist. If we can't see who's getting sick, then there's not a whole lot of data we can produce. And so in rural or underserved communities, you may not have that data. I will also tell you, and I'm talking about Texas, okay, because that's where my experience is. When I was working at a large urban health department, Houston, we had a number of epidemiologists on staff. I often talked, because I actually did some work with TACHO, the Texas Association of City and County Health Officials. so I talked to health department directors from these rural areas. And one in particular, he used to always tell me, I wish I had a Kathy, i.e. me, but he couldn't, I mean, not that I was going to move to rural Texas. I told you my husband was at Rice, but he didn't have the funds to pay epidemiologists. One thing you probably should know is that epidemiologists can get higher pay than others because of their training and their importance. So it is difficult now in Texas, you know, that we have the state health department, and in areas that either don't have local health departments or are underserved, then the state department through our regional health departments will step in and help. But it is a problem when you don't have the resources. Let me look at my slides. Is there another question? Oh, okay. So epidemiologists love data. That's our bread and butter. That's how we understand what's happening in a community. And there certainly are different types, lots and lots of different types of data, and it depends on the problem that you're studying. I mentioned just basic stuff, demographics, males versus females, age groups, maybe zip codes important. Dates are important, date of onset of a disease, particularly an infectious disease, where we're more likely to know actually what day the person got sick. But there's other types of data we can get. So that's quantitative data. It's from the word quantity, where you can measure it. You can say there's 5 of them or there's 3 of them. We also rely, again, depending on the type of problem that you're studying, qualitative data. This is, so you can't measure it, but you can talk to people through focus groups. Because again, let me go back to I get bored easily. I've done work with the unhoused in Houston. It's not infectious diseases, but it used my epidemiologic skills. And I did focus groups. I would talk to people who were unhoused to get their opinion about what they needed to help them. And, I live in a bubble. I think we all pretty much do. And I could say, well, I think what the unhoused need is this, but I don't know. It's much better to get that information from the people who are actually affected by a problem. Right now, I'm involved with a HIV study and wastewater. And in fact, here's a good example of a type of data. You may have heard about how we are looking not just, and I mean public health, because this is happening around the country. Wastewater is being used to detect mostly infectious diseases. Because almost any bacteria, virus, parasite that someone may have, it's excreted through your feces. And unless you have a septic system or an outhouse, if those still exist, you're depositing those feces into the wastewater system through your toilet. So we are collecting data from everybody. With those few exceptions, as I said, and babies in diapers, that's another thing. But so we can test the wastewater and find out what's happening in a community. Again, I am involved in a HIV study where we're looking at the wastewater to look at HIV. Can we detect it? If we can find it, we are technologically capable of detecting it. If we find it in a community's wastewater, that means either somebody hasn't been diagnosed, they don't know that they have HIV, or they have been diagnosed, but they aren't on therapy. If you are on antiretroviral therapy, you can get your HIV rate down to undetectable. That means it basically isn't in your system, so you're not excreting any. So by looking at different communities and areas within Houston, we can see where we're finding HIV, which we are working with the Houston Health Department so that because this is what practice does, they can increase testing in that area and prevention messaging. But back to the types of data, we are getting, besides the quantitative data from the wastewater, we are getting qualitative data from people. You can see where this might be a sensitive topic. And so we are doing focus groups with a variety of people, people who have HIV, people who live in these areas who do not have HIV, with environmental groups, because this is a water issue, et cetera. So that's another type of data that we can get. How epidemiologists spend a lot of time trying to ensure that the data is reliable and unbiased. Sometimes not as easy as you might think. First of all, I mentioned with wastewater, unless you're on a septic system or in diapers, and that could be young or old as well, you're contributing to the system, basically whether you want to or not. So your excretions are being tested. So that's unbiased, again, with those two caveats, because everybody's contributing. If a researcher is doing a study where people have to consent to be in the study, they have to agree to it. And, you know, that's a very important part about research, is getting informed consent. People have to know what they're being tested for, how the pros and cons, if there's a risk. But many people will say no for different reasons. Time, they just don't want to do it. And there is an inherent difference between people who participate and people who don't. And that's just something we can't control. But that's one way data can be biased. Even if you're looking at, let's say, the COVID rates back during COVID, and you want to know how many cases this week. Well, it depends on somebody being sick enough to go to a doctor, and be tested. And both of those things may not happen. And the reason someone may not go to the doctor, maybe they're not sick enough. Maybe they don't even know they're infected with COVID. You can have a subclinical infection. But maybe they can't afford health care. And so that's always an issue too, about the data being biased. How we try to improve reliability is by looking at data from different sources and triangulating it, so that if one source says COVID rates were 100 per 10,000 people last week, we want to look at another source. Excuse me, just one second. We want to look at another source and see, does it say, okay, I've told you one source says 10. Does it say 100 cases per 10,000? Something's weird there. Does it say one case? Maybe something's weird. So we want to see if different data sources agree. Sorry, I am on a new asthma inhaler that is playing havoc with my voice. One of the things it's important to talk about with epidemiology is that, for the most part, epidemiology does not show causation. That means it can't say that exposure to A causes disease B. We can say people who are exposed to A are more likely to get disease B, but there are often, we call them confounders, other reasons why there may be an association that's not causation. I'm debating whether I should use this example or not. Maybe not. The other thing, and that's why we have control groups for a lot of reasons. For example, if you look at people who commit murder, 98% of them eat white bread. oh my goodness, does that mean white bread causes people to become murderers? No, it means that the population, I'm making that up, I don't know what percent eats white bread, but I would be really surprised if it differed between murderers and non-murderers. And that's why we need control groups where we would look and we say, oh, there's no difference between those two groups. So that's another thing about epidemiology is it's very hard to show causation with epidemiology. We have other ways of doing it. We're looking, mostly we are determining association so that further studies can be done. All right, what's the next slide? All right, I think I answered this, that, you know, I was
Yeah, I was
interested
gonna
in
say you went through your
biochemistry.
journey. Yeah, you went through your journey. Is there
Yeah,
anything else you wanted to add to that?
no, I think I covered it in great detail.
I think you did. It was great. All right. What is the typical educational background or training that is required?
So, because I have a faculty position, that requires a PhD or an MD or some terminal degree. So, if you are interested in teaching at a college or graduate school, a PhD or again MD is almost always required. Now, for public health practice, it's not so necessary. Um, but it also depends on what you're doing. There are larger health departments will require their epidemiologists who are actually out there investigating disease outbreaks to have a master's of public health. But that's not true everywhere. And you can get, I mean, we have a lot of undergraduate degrees now in public health, and that will provide you with some training. So I
So what
liked you.
skills? Yeah.
Yeah, I liked what you had at the beginning, the answers to your questions. Although I was thinking those are probably true for any job. Communication is necessary, collaboration, knowledge. I think in epidemiology, besides the knowledge, and again, as an infectious disease epidemiologist, I think some knowledge of the bug you're studying is really necessary. So I have studied respiratory and bloodborne viruses a lot. So it helps when looking at how they spread in a population, you know who's at risk, you know how to kill them, you know, that kind of thing. So some background biological knowledge is good as well. Leadership skills are really important, particularly if you're in a leadership position, but even if you're not, they're still important. Curiosity and lifelong learning is really important. And especially in epidemiology, I think, well, critical thinking. Again, that's something that's important for everything, but really important for epidemiology. And not taking things at face value, but asking the why behind it and what are some other explanations. And then flexibility, because particularly in public health practice, you're going to be called to do a lot of different things, and that makes it exciting. But you can't say I only do this one thing and I'm not going to do anything else. That just doesn't cut it. There's such a need at health departments for well-rounded workers who can tackle a number of problems, that is a big benefit. I would also say, and again, I think this is probably true for almost every job, writing skills. I have gotten work because I'm a good writer. Unfortunately, that skill is not out there everywhere. So learning to write well is important. Public speaking, as I said, the reason I've been asked to do so many media interviews is and you know, y'all can tell me afterwards, but I'm pretty good at taking more complex issues and getting out of that academic speak and talking in language that the general public can understand. But that's an important skill no matter what you're doing, because as a public health person, you will be interacting with the public. And so cultural humility is important. Not thinking, public health used to have a very paternalistic attitude. We know what's best, just like medicine did. We know what's best for you, just listen to me, I'm the expert. That doesn't work anymore. And you have to have some cultural humility, be willing to listen and talk to someone in language they can understand.
Mm. So the next question is, what is your advice to someone who is pursuing an MPH or coming into public health and epidemiology in 2025?
So this is a weird time for public health. If you had asked me before the pandemic how public health would be treated, I would have said we're going to be the heroes, right? Yeah, it didn't really happen, and there's a lot of distrust in public health. We have to get that trust back, and unfortunately, that lack of trust is leading to lack of funding. And so, to be honest, it's a difficult time because health departments are seeing their budgets cut, universities are seeing their budgets cut. You can certainly work for a nonprofit. They're also, I assume, I don't have direct knowledge, but I assume their contributions, how they get money, isn't so great either. There aren't grants out there like there used to be, NIH and NSF. So I think the best thing now is, learn what you can, get a well-rounded education, and be flexible in what you're going to do with that MPH. Maybe right now, if your dream is to work for a health department, maybe that's not going to happen right now, but find someplace else where you can still use your skills and work towards when things turn around. They will. I don't know how many of you are familiar with the musical Hamilton, but there's a King George sings a song called "You'll Be Back,"
Yes.
and talking about how the colonies are revolting, but they're going to be back to him. You'll see you've missed him. And honestly, I wanted to use that the public right now may not be keen on public health, but they're going to come back when they realize we're doing it not for our own. We're not making money off of this. We're doing it to help people. And I think that will become clearer. Higher education is changing right now. It's unclear what it's going to be in the future. And again, flexibility is the key.
I appreciate that optimism. Okay, we also pulled some questions from the registrations. What are some good technical skills outside the main set of core competencies that helped in your workplace, which you already brought up the writing skills being invaluable. What are some others that you can recommend?
So I will tell you something else that's helped me throughout my career. And I didn't realize it for a while, but I mentioned when I was at Michigan, I worked in a lab. I mean, I did influenza studies in a lab, bench work, and besides studying epidemiology. And that's just how Michigan does it. Everybody who worked there did both. That's not as common. And I didn't realize that for a while. And I was on an NIH study section where we review grants. And one of the other professors who was on this from another institution, I don't remember where, told me what a great background that was, because I knew the lab part and I knew the epidemiology part. So, I mean, not everybody's going to do that, but that really has helped me. That and the biological knowledge of the viruses that I'm studying has really helped me throughout my career. Math skills are definitely necessary. I know I'm an outlier. I loved biostatistics. I almost majored in biostat. But, it's very hard to do epidemiology without knowing some biostatistics. And the more you know, the better. So, and now learning coding languages, things like data analysis methods are really important.
So this question was a little abbreviated, so we can only assume, but the question or the statement was opportunities for doctoral studies. So,
Yeah, that's
okay.
an interesting question this year. So there are lots. When I actually didn't go to a school of public health. I was in the graduate school at Michigan, but they did have a school of public health. And there were something like 20 of them in the whole country. I don't know how many there are, but many now, but the many, many more times that. So there are many places you can go for doctoral studies. And I should have said earlier, in in public health, there's two different degrees you can get. You can get a PhD, just like you can get a PhD in history or literature or French or whatever. Or there is a doctor of public health, a DRPH. The difference, there's a lot of overlap. The difference is that PhDs usually study one area in great depth. So had I stayed in biochemistry, I would know a whole lot about one protein, and that would probably be it. DRPHs are considered a practice degree, that if you're really, you want to head up a health department, you want to be bureau chief for epi, that's a good degree to have, because you may not get the depth, but you get the width. You get a broader education in public health. Now, as I said, there's a lot of overlap. I mean, I have a PhD. I was at a health department. We have DRPHs on our faculty. So that's something to consider. Now, back to this question. The reason I said this is a tough question right now is that there are some schools, Michigan being one of them, that did not accept any PhD students this year because of the funding issues. And we can only hope we get past this and people realize how important public health is to the public's health. And yeah, so again, lots and lots of opportunities. And I would suggest that there are various considerations where a school is located, and if it's a state school, UT Houston School of Public Health, our tuition is very affordable if you're an in-state student versus some private universities. But also, you want to look and see that there's faculty who study what you want to look at, and you may change your mind, but you don't want to go to a place where you're interested in diabetes in children and there's nobody who's looking at that area. So look at what the faculty do.
Okay. I think we're going to circle back a little bit to the technical skills with this next question. Do you suggest learning Python or RStudio for epidemiology?
Yeah, so both are useful. There's actually a lot of overlap. And here at our School of Public Health, faculty do both, or one or the other, but again, a lot of overlap. So I don't know, I guess you could try each and see which appeals to you more, but there's no right answer there.
So how do you start an investigation? How do the PH labs help?
Oh, okay. So, full disclosure here, when I was at the health department, I was not in the epidemiology department or bureau, they call them. So I have never been out in the field running an investigation. I certainly know a lot about it, though, just from, observation. So what usually happens is reports will come into the epi department, and there are a lot of ways particularly big health departments have for seeing what's happening in the community. We have, for example, syndromic surveillance, which doesn't tell you COVID is happening. It will tell you influenza-like illnesses, high fever, respiratory symptoms are happening. It could be flu, it could be RSV, respiratory syncytial virus, could be COVID, it could be a number of things, but it tells you something's happening in the community. We also have lab testing. So those reports will get to the Epidemiology Bureau as well. So let's say, and sometimes it's just people calling in. Let's say somebody calls into the health department and says, I ate at restaurant B last night and today I'm sick. Now, it could be from what you had at the restaurant or not. But now you get a bunch of calls that say, I ate at restaurant B and I got food poisoning. You would send somebody out there to look at the restaurant. Are they following the health guidelines or not? Sometimes, sticking with food poisoning, sometimes people get sick, but they don't know where they got it from because we all, eat 3 in general meals a day, probably some at home, some not. So then they would find the people. You have to have a case definition, usually there's a time period involved. So someone who had GI symptoms between this date and lived or ate in a certain geographical area. And you do a questionnaire. Did you eat this? Did you eat this? Did you eat this? And then you see, did your cases, are they more likely to have eaten a certain food than another? Let's talk about TB. Somebody is diagnosed with tuberculosis. In that case, we do contact tracing, just like you may have heard about with COVID. And with TB, we start with what's called ring investigations. So you start with the people who are in closest contact, who are usually the family, and you test them. If none of those folks test positive, you may reach out to coworkers. If none of the coworkers are positive, because TB isn't spread easily, or you need prolonged contact, unlike COVID, you may stop there. But if you find a positive, then you go far, you people who've had a little less frequent contact. And but you do that testing, and then if they're positive, get them on treatment. With COVID, well, let me use measles as an example. Measles was a little harder for a couple of reasons. One is that the incubation period can be longer. I mean, a week or 2 weeks, so that it's a little hard to remember where you've been 2 weeks ago or who you might have come in contact with. Secondly, people can be infectious before they have symptoms, just like COVID. So you may not even know you were in contact with someone who was infectious. And thirdly, with measles, the virus can stick around in the air for 2 hours. So someone with measles who's shedding virus could have gone to HEB, left, you go there an hour later and breathe in the virus and you get measles, assuming you haven't been vaccinated. And you don't even know that you've come in contact with it. You haven't come in contact with somebody. You've come in contact with the air. So those contact investigations are a little harder because it's more difficult to determine if contact took place or not. But certainly when we do know we had a measles case, there was someone who had was symptomatic, had traveled, or I guess they were pre-symptomatic, but in the infectious period, and seemed to have been looking at colleges, had gone to a number of college towns and exposed people. So there, you may do more testing. You certainly do public health announcements of what measles looks like and what to do if you think you may have it. So again, it's depending on the disease, and the public health labs often are a lot of help, again, depending on what you're looking at.
All right, we have about 5 minutes left with a couple already preliminary questions and a few in the Q&A.
I'll be short. I'll be briefer.
What are some job opportunities for people wanting to get into the field without a background in public health?
So, health departments will often hire folks without a public health background. And sometimes, like I know I'm working with the Houston Health Department on some basic public health training for their folks. So you can get it on the job, the training, depending on where. But skills in psychology and sociology, really any liberal arts area, never mind if you have more technical skills, often you can get hired and get experience on the job.
Awesome. Okay, and then do you have any additional resources where people can learn more about epidemiology?
Well, I will put in a plug for TEFI, where we have training. We have a free certificate program in public health preparedness, and I didn't even talk about that as a field. But one of the courses is basic epidemiology. So that's a good way to get your hands wet and see if it's something you might enjoy. And it's TEPHI, TEPHI.texas.gov.
Awesome. Okay, I think we have some questions, Amel, in the Q&A.
Yes, thank you so much, Dr. Troisi.
Awesome.
That was an amazing presentation.
Amazing.
We do have 4 questions. I think you touched on some of them, so we'll go kind of quickly. Our first question is, given your experience, how have you seen the field evolve with the rise of social media as a fast-paced and influential communication tool?
Yeah, I do a lot of vaccine work and vaccine misinformation, and social media has been devastating for misinformation, not just about vaccines, but about a lot of stuff. Yeah, it's a good way to spread correct information as well, but probably we don't use it as skillfully as we could because of old people like me in the field. And hopefully you young people will be more savvy at how to harness the possibilities of social media to get correct, accurate information out there, because there's an awful lot that is not accurate, and that is leading to a lot of the vaccine hesitancy that we're seeing.
Yes, absolutely. I think that's a great answer. Our next question, you kind of touched on this with the pre webinar question about Python and R, but this student was asking, what data programming software do you recommend that they focus on to be prepared post-graduation? At their school, they're learning Stata.
Some places use Stata, some places, and I'm talking about health departments, use SPSS. Stata's fine. But the larger number of programs, the better. But Stata will do you well. And again, it just depends where you're going to work and what most people use.
Absolutely. Thank you so much. And then just 2 more questions. This one is there any position one can get into without a public health degree? You mentioned a little bit about this, but this student is asking specifically with somebody who's experienced in research, an experienced research associate with a master's in molecular biology.
So I'm not clear whether they're looking for a health department job or in academia as a research assistant, although it sounds like they're already doing that. Yeah, I think molecular biology, that's a great, and if you have lab skills, certainly the public health labs need people. It's always hard to find people with lab skills. So that's certainly a possibility. But as I said, my biology background, my lab background has really served me well. So I think, I can't speak for every health department out there, but I certainly think you can find that and play up those skills as, as being valuable.
Yes, absolutely. All right, and then this is our last question. It's referencing the wastewater monitoring and testing that you mentioned earlier on. The question is, how do you test it, and how do you deal with sampling and sensitivity or specificity?
Yeah, that's a great question. And sampling, I mean, there are different projects doing it. And in fact, Dana, could you put the text web in the chat? This is what one big wastewater sampling project I'm involved with throughout Texas. So, the people go and collect samples and send it to the lab at Baylor. We work with Baylor. And you asked about sensitivity and specificity. Interesting question, because we don't have gold standards. We can spike water samples to see how low, what's the lowest amount we could detect. But that doesn't mimic the environmental conditions. So when someone flushes a toilet, it might be 100 degrees outside or hotter in parts of Texas. So the water's hot. That may affect it. It might be during a winter freeze and the water's much colder. Maybe that affects what we can detect. Specificity, we're less worried about specificity because of and that's how sure are we that if we say it's measles, it's really measles and not mumps. We're less worried about that because of the analytical tools used, which is PCR. And but I will tell you that at least with measles, if we don't detect something, we can't say it's not there. We just say it's, at the level of detection, whatever it is, we're not finding it. But with measles, we have the other thing about wastewater is in urban areas like Houston, so all of Houston is not on the same, it doesn't all, there are different sampling sites.
Right.
Some of those sampling sites cover 10,000 people. Some of them cover 100,000 or more people. So there's also the dilution factor. But we have found with measles that we seem to be able to detect just 1 or 2 cases of measles in a catchment area, which is pretty amazing.
Yeah,
Right.
that is very
Sorry.
impressive.
All right, I think that we have gone a little bit over, which is great. More information, the better. We wanted to go ahead and post a few of the schools in Texas that do offer public health postgraduate degrees. So a lot of good options. I know UNT just moved to Fort Worth and have some fantastic new buildings, and UTHealth is also coming into the modern age.
And Dana, can I just
yes.
add that at UTHealth, we have online degrees as well. There's an online
Yes.
MPH in epidemiology, as well as some other areas. But you can
Yes.
get an MPH and never have to try to park in the medical center, which is a big plus.
Absolutely. Okay, so thank you so much, Dr. Troisi. There was so much wonderful information. And we ask if anybody has more questions to go ahead and post them, or you can email them to us and we'll do our best to answer them. But thank you so much for spending time with us today.
Happy to share my love of epidemiology.
Yes. Hopefully you sparked some interest in some of our attendees. So everyone, please do us the biggest favor of finishing or completing the feedback survey, the QR code on the left. This tell us what you'd like to see going in the future. Tell us, what you thought of today's presentation. And then on the right, that is the QR code to join us at the Public Health Workforce Pipeline. There's resources, there's collaboration opportunities, and a lot of career connections. So if you want to join us, scan the QR code on the right. And if you have any more questions, please include them in the Q&A. Thank you, everyone.
Bye.
And thank you again, Dr. Troisi.